Good morning to everybody, and special thanks to all my friends from Seattle that gave me again the honor to be with you and to speak here. My talk will be on the developmental and degenerative scoliosis, a common rotatory phenomenon, decompensation. And we will see if something works like that. To simplify and visualize, analyze the horizontal plane in 3D, one of my pupils, Tamasiles, designed the 3D vertebral vectors that allow to measure, to quantify, and especially to study the horizontal plane. And you see here the normal spine and the right thoracic scoliosis pre-op and post-op, so we can analyze easily the problem. Because this view of the horizontal plane improves clearly the evaluation when you see at the bottom of the slide, and quantification of the result. And each planar can be identified, studied individually thanks to this machine. For example, you will see here a real rotatory mechanism of the deformity. You see the time compression allow to see. No, back. I want to go back, but I don't know how to do this. Linda, you have to help me. Yes, I want to see the. I want to see the. Voila. I want to see the video. Look to the video, and you will, with the time compression, you will see very well that is a rotatory mechanism of this deformity. And you see from the top, no, back, toujours back, always back, because, no, back, toujours back. No. I don't know how to make working clearly there. You have seen the video. I want to show you, to put it in your mind very well, this rotatory deformities. It's a rotatory inductive deformity. But here, it is the same, but I don't know how to manage the video. Je ne sais pas. Voilà, the video, it's coming. You will see here the same thing, I hope. Voila, you see very well as the pelvis coming there. And for example, in this case, you will see the correction of the deformity. You see, thanks to the vector system. And we had a consensus for that from a long time. But recently, we did this consensus with René Costolin and Jack Chang, and we wrote a small paper that you have the reference here. When it's clear that the rotatory decompensation mechanisms is there. And I have this in my head from a long time. And you remember that I presented at the SRS meeting in Chicago in 1980, that the prognosis of infantile was very easy when you see view from the top of the projection of the deformity. But I was not understood, of course. When I describe the crankshaft phenomenon, it is the same thing. You look to the X-ray, you look to the patient. But if you look from the top, like you see on the right, you understand so well that it is a rotatory problem and not a collapsing problem or what. So scoliosis for me, two different entities. The developmental that start in the childhood, worsening torsion with growth, secondary to genetic, etc. But when you see from the top, the horizontal part concern is really evident. But it is the same thing for the scoliosis that arise at the adult age, because here the degeneration is the primum movens, but it is a rotatory collapse with the thanks because of the discogenic collapsis factor. And the starter is always a transversal plane failure. So clearly, we see here another case where the horizontal plane failure is evident. And you must remember that the worst place on the spine is the junctions between the curves because of it. So the management of degenerative scoliosis, when you consider only the angle and the incidence angle, all the formula that are there, scoliosis, kyphosis, Rusuli type, ignoring the horizontal plane is for me a mistake. Too much ignorance about the location of the mass, and it's necessary to find an easy, reliable way to measure the barycentrometic in erect posture, as well as checking the movement. Balance of the trunk, not a question of angle. It's a question of 3D plane hubs of the body mass in the horizontal plane regarding the gravity axis. And mass are balanced thanks to the power of the muscles. And when you ignore this concept, when you do your surgery based only on calculation of the projector angle, from time to time, you remove the compensation problem. We are too much addicted by the angle, and we must evaluate each segment for the volume, the density, the mass, and the barycenter. And this is important because with EOS imaging and 3D reconstruction of the external envelope, we can get a personalized barycentrometry very close to the reality when you are measuring also the gravity axis. 3D dynamic evaluation, it's for me the way to get something about the dynamic balance in the space. But it needs a sophisticated device, but you can approach the economical balance in this economical balance that I described with the cone of economy. Because when you are here, for example, when you measure the flexion on your patient, it is always good. Flexion is good, but extension of the trunk is declining with time. So if you measure this, you can detect the time when your patient has to be operated on and not to wait that all the respiratory, cardiac, etc. function are declining. So I'm wrong on the arrow. Right? So you can measure in standing position by measuring the active movement, flexion, extension, even on the hip. You can do something similar when you are in a prone position, of course. And very often you got this too much hyperjunctional kyphosis. Is not a question of hook, screw, wire. It's a question of local balance of the head, because you know that the head is heavy. And I describe when I was invited in a meeting in Miami, a long time ago, 2011. I described that I called at that time the spine like a statue. And where you have such instrumentation, you have only two places to move, cervicothoracic motion and hip motion. And when you are doing too much lordosis, for example, you have a retroversion of the upper patch and the shoulder, so you cannot escape the junctional kyphosis. This is really clear. In my practice clinic, I used to use when I was seeing patients this very simple functional measurement: walking 5 meters straight, forward, backward, and measure with the chronometer, nothing else. Speed and ease to climb 3 stairs, go down. Speed and ease to squat and get up. For me, it was the most discriminant, because with time, you see your patients that take more time to do that. And of course, to check about the cognitive function, you have to check walking while speaking on the telephone. And this is a simple way, very simple. You can do this during walking, because the rotatory concept is important. It's important because the horizontal plane motion, it gives a permanent adaptation of the joint regarding the gravity and motion. Harmony in motion comes from the horizontal plane. Poorly documented, very often ignored by the orthopedic surgeon, much better understood by the orthosis and prosthesis people. You remember that in the past, Ducroquet brother in 1965 described the pelvic stair, that is the motion of the shoulder and the pelvis during walking in a reverse way, very harmonic. You see these patients that I treat in 1984, the spine was not straight, but perfectly harmonious, and remain after that perfectly harmonious. So in reality, the philosophy of the CDI in 1984, when I start to do the 3D reconstruction and plaster cast molding, because we have not technology at that time, I had the intuition that the mass were more important than the angle. And important thing to have to remember, you have not to confuse alignment and balance. Alignment is static, but balance is dynamic, and balance is the stability during the movement. Important also to understand that it is not the fused and instrumented part of the spine that is the most important. It is the not fused area above and below, because the goal is harmony. And as was saying my friend Alain Di Meglio, the maximum reduction is not always the optimum. You have to see this patient, and that I treat in 1986, you see the shape of his thorax, and I decide only to fuse the upper part only because I saw that the lumbar spine was completely detoured when I was doing traction and mainly bendings. And you see that 30 years post-op, the patient is still perfect. So now there is the use and everybody wanted to put screws everywhere. Is this okay? No, for me, no, because it is not harmony. What is harmony? Harmony is very important to introduce in our language. It is a concordance, it is very well seen. For example, when you are in a concert of music, very good concordance between the part of the tune. It is a rule of physics. And for the pictorial arts is accordance in the arrangement of the colors. But of course, it's really difficult to introduce in the language of the spine surgeon, because it is very subjective according to the education tradition. And it is why very little was done to use this word for pre and post evaluation. When you look at a human walking in the street, climbing, doing stair jumping, you detect in a glance the harmonious and disharmonious movement. You check it in a 3D walking laboratory. Harmony in motion come from the horizontal plane. Very little adjustments, small adjustments that are made. What is harmony? It is a good, pleasant adjustment according size, shape, weight, alignment, movement. And what is harmony for shape and movement? This was defined by a professor of anatomy, a School of Fine Art in Paris, long time ago, in 67. Harmony of the movement is the right distribution of the mass, cephalic, thoracic, abdominal, hanging over the lower limbs during move. So you can have this in small, large people, small or hybrid shape, heavy or light people, well aligned, but exceptionally malaligned, and fluid and balanced movement. This is harmony, requires a 3D smooth alignment, an acceptable arrangement of the mass, a 3D static balance within the small code of economy, a 3D motion within the normal functional, and we are very far from the gold standard Cobb angle because everybody, always, it is the Cobb angle. The Cobb angle measure only the collapsing of the spine, nothing else in my mind. So it is necessary to consider that I say mass, volume, movement, and it is a lot of work to do for the brain of the researcher. It will be the goal for the treatment of the spinal deformity in my mind. And for me, the 3D dynamic of the past, remember my very, very juvenile drawing of the basic principle for the CD, the sagittal, horizontal, and frontal. And this show only that we must have a reserve of motion in each of the three directions from the gravity line. And this became to be recognized, this horizontal vision. And you know very well the work of Isadore Lieberman and Ram Adams from Dallas that designed a method to quantify the cone of economy. And perhaps also you know the work of Kazu Azewaka from Japan that show the whole body alignment. It can be evaluated by the top view, and you see if you look to the slide, to the bottom part of the slide, you see very well the shape, including the head, including the knee, including the feet. It is very useful and reliable. So look more on torsion apical, but mainly junctional than the Cobb angle. Forecast brace treatment to assess the efficacy for assessing correction of the instrumented, not instrumented part of the spine. Remember that alignment is not balance. Look on balance of the global body and segmental. And balance, for me, is the best productive factor for longevity. So the final goal for me is, and last message, harmony much more important than the Cobb angle. And last message for the young researcher, shadows are multiple. Everything remains to be done. New horizons are numerous and infinite. And like my father in teacher and in orthopedics, nobody knows. It is Pierre Conneau who told me, remember that Matthew says, seek after, and you will find it. Thank you very much. And I can try to answer your question as you want. Thank you, my dear friends.
That was a great talk, Professor Dubousset. What are your thoughts on, do you think, so I know scoliosis is a very broad topic. And what are your thoughts on adolescent cases right now? Do you think that we're doing too many surgeries and not enough bracing?
No. I don't think that. I think that I found more and more that in adolescent, the extension of the fusion, it's a little bit too big for me, too many, especially at the upper part when you have not the ability to leave the level of the shoulder able to compensate to move a little bit. So it is for me a little bit concerned for that. And I really prefer the fusion on selective part of the spine, not completely, because you have the upper junctional kyphosis, but after, when you look to the lower part, and if you extend more and more, you have very little motion segment to make this adaptation, compensation, you can call as you want. So this is my impression now.
Jean, Dr. Ale, a fantastic talk, and I appreciate all your advice. And I remember taking back some patients to the OR to remove some implants so the curve would get larger, so patient would get better balance, which is in keeping with what you said. Harmony is better than correction. Now I'd like to pick your brain on the adolescents. What are your thoughts on the vertebral body tethering that to get progression of the curve with a tethered, it's like a textile tension band on the
I know the technique. The problem is always to have a good location of this cedar, because it's not so easy when you are in the front to check the good entrance of your screws. You must study this on the horizontal plane. And the other problem is from time to time you get hyper correction, but not in a good direction, and it is difficult after to correct it. So I am not against all this technique. Of course, they must develop, but it is really necessary to make some improvement to check very well the positioning. The other thing is that doing this, you are a little bit aggressive. People say that you are not so aggressive. I consider that it is not so benign. It's something important. Aggression for a mild curve very often. And they don't treat very well the junctions. I have seen some cases, it is the junctions are not very well defined.
Thank you.
Professor Dubousset, we have one more question. And then
you can ask.
As you go to the lab. Is one of the, there was an excellent question on what do you think is a better way to restore shoulder balance for idiopathic thoracic scoliosis? Is it to go anterior or posterior? And I'll open that up to the panel, but I want to first see what Professor Dubousset says.
Yeah, to check the shoulder balance, I check this on the possibility of the patient to make some self-correction. And it depends of the location of the upper instrumented vertebra. Because in some cases, when you extend your fusion at the upper part on only one level too much, you remove the possibility of spontaneous correction. So for me, I decide this, and on the bendings of the upper part of the spine, especially on the upper part. And I try to not go one level above the limit of this. Treat from the front, I don't know if this changes something. I'm not sure.
What do you think, Vince, Manish? I know what Dr. Arle is going to say.
Oh, for the shoulders?
Yeah.
I think it's more important to look at the patient from the front and from the back than to look at the x-rays.
I think also I like the idea of not going up to T2 every case. I think if there's some mild asymmetry, stop short, like Jean said, go to T4 and not go up high, because then they lose the capability of adjusting their shoulders. And frequently I see a lot of people and they go high and then they can't adjust and then they're stuck in that position. So I don't like to go to T2 just on a whim. I like to make sure that they really have a rigid upper thoracic curve before I go to T2.
I completely agree, Manish, completely.